Kia ora everyone, welcome to this Goodfellow Unit Webinar, kindly supported by Mercy Ascot on chronic pelvic pain and gynaecological cancers. My name is Dr. Helen Fulcher, I'm a GP, and I'm moderating this session with our two expert speakers, Dr. Sarah Corbett and Dr. Silipa Naiqiso from Ascot Central Women's Clinic. Dr. Sarah Corbett is a specialist gynaecologist with a special interest in gynaecological laparoscopy and minimal access surgery. And Dr. Silipa Naiqiso is a specialist gynaecological oncologist with a special interest in the surgical management of precancerous and cancerous lesions. We welcome everyone's questions tonight. Please type these into the Q&A section at the bottom of your screen. And I will now hand over to Sarah and Silipa to start the session.
Kia ora everyone. Ko waio. So, ko Sarah Corbett toku ingoa. No Te Arawa here. So my father's side, my family are from Te Arawa, Rangiwewehi, Hapu. And so this is a little picture of Makoia Island, which is where my great-grandmother, who's down here, her great-grandmother was taken from the island by Hongi Hika, taken up north. And on my mum's side, they were Albertlanders landing in Wellsford in search of a better life. This is who else I am. I currently work at Middlemore Hospital. There's a photo of the three, me and myself and Anna-Marie van der Merwe are the current complex endometriosis surgeons there. And there's a new specialist joining us next year called Anna Broughtonson, which we're really excited about. I work in public and in private at Ascot Women's Clinic. I'm also on the Ranscog Māori Women's Health Committee, and I've got my two young kids as well. So that's my full life. So what I'll cover today, I'm going to cover basically a brief way to consider causes of pelvic pain and their management, how to explain this to patients. This is what I do day in, day out. What I'm not going to cover, I'm not going to cover an in-depth discussion about sensitization, MDM management of chronic pain, like you get from a pain team. Why? Because I'm a surgeon, I'm quite simple-minded. I'm not, that stuff's quite hard for me, but I think also, to be honest, 90% of patients, the approach that I'm going to talk about is enough. The other patients that it isn't enough, they're hard for everyone. I struggle with them too, but I think if we can do the basics right for everyone, then we'll be a lot of the way there. So this is the way I think about it. On the side, you're going to see this hand quite a few times, because as I said, I'm a simple-minded person. I've got to have a way of remembering things. So when I think about possible causes, I go through this. I think about, is it the uterus? Is it endometriosis? So is it adenomyosis, endometriosis? Could it be the bowel? Is there any element of bladder pain, pelvic floor pain, central sensitization? And then thinking about it underpinned by trauma, adverse childhood events. We know that's got a high correlation with pelvic pain in later life. And then I think about global things like stress. And I know there's connective tissue disorders, which I also, you guys probably know a lot more about that than me. But I think just being more and more aware of other things that can cause pelvic pain that are kind of on the periphery, but actually a significant number of patients probably have these issues. So I'm mostly going to talk about endometriosis. There's different kinds of endometriosis, which is important to know. So there's ovarian endometriosis, which is when we get a cyst in the ovary that bleeds into it every month and causes an endometrioma. This is the chocolate cyst because it's filled with old blood. We can diagnose that on an ultrasound scan. So I'm not sure if you can see this, but this is an ultrasound scan with this classic appearance of an endometrioma. So if we're doing a scan and we see that, we can know 100% this patient's got endometriosis. We don't have to do anything else. That's enough. Then we've got deep endometriosis, which is the endometriosis that fuses the organs together. This is the stage 3, stage 4 endometriosis. So for this person, they've got their bowel stuck up to the back of the uterus and their ovaries might be stuck in. These are the ones that can cause problems with the tubes being blocked, which can cause issues with fertility. More and more we can see this on ultrasound scan, if in the right hands. So with the right scanner, they can see all of these nodules on ultrasound. This is not happening in a lot of units, but more and more we're seeing this. And ultrasound in the right hands is all that people are doing these days to look for deep endo. We can also see this on an MRI scan. We can see deep lumps of endometriosis. There's the red, this person's got the uterus here, the bowel is the black bit, and this grey lump is the endometriosis growing into the bowel. So we can see this on MRI. The other main common type that we see is superficial endometriosis, which are these kind of blebs here, these red blebs, these white blebs, the scarring. And this is endometriosis that we can't see on ultrasound or MRI. And this is a very common type of endometriosis. So this is the difficulty in diagnosing this without surgery. We also get some rare types, like extrapelvic endometriosis. So I mean like the endometriosis on the diaphragm, weird and wonderful stuff in the brain and the eye. Diaphragmatic endometriosis is not that rare. You can also get it on the pleura as well. So people can get monthly bleeding into their pleural cavity or pneumothoraxis as well. And then we have adenomyosis, which you can see on an ultrasound. And there's a high correlation between adenomyosis and endometriosis. So if you see adenomyosis on an ultrasound scan, always be very suspicious that they probably have endometriosis too. So the reason I'm really talking about endometriosis is because we know 1 in 10 women and people assigned female at birth have endometriosis. That's a huge number. So I kind of think if we have someone coming to us complaining of period pain, most people put up with a lot. If they come to us telling us they've got period pain, if we have as a primary diagnosis endometriosis, we're probably not going to be wrong, to be honest. I remember, I think things are changing. We're getting better at diagnosing as well, but it's very, very common. And I'd say, especially if it's a Māori or Pacific woman coming to you about period pain, 100% they're going to have endometriosis in my experience. So I think there's still a lot of women who have a lot of difficulty with getting validated or believed by health professionals. So I think we have to make sure that this is not really in the front of our minds when someone comes to us with these problems. So I'm just going to talk a bit about how we can make a diagnosis. So the history is really essential. Basically, from a history alone, you can tell that someone's got endo most of the time. So we think about the 3 Ds. We think dysmenorrhea, dyschezia, which is pain when you poo during your period, and dyspareunia, particularly deep dyspareunia, deep inside with sex. We ask people about their period pain. The classic things for me are pain that starts even before their period. So if they start to get flow-related pain on day 1, that's probably could be more normal. But pain before the period is generally endometriosis, and pain with ovulation, you have to think about endometriosis. And if they're having a big impact on their life, if they're having days off school or university or work, then that's, highly considered endometriosis. Other symptoms that people get with endometriosis is irritable bowel syndrome. Almost all my patients with endometriosis have IBS. That's part of the endo. It doesn't mean they've got lesions on their bowel. It's like how people get fibromyalgia of their somatic muscles? You can get a visceral hypersensitization, which can cause IBS and also a lot of bladder symptoms. So a lot of my patients with endo tell me they feel like they get UTIs all the time, but they never come back positive for testing, or they might get a lot of urinary frequency. So that's part of the nerve wind-up in the pelvis. Other things with the bowel, if they're getting cyclical rectal bleeding, they might have very rarely people can get endometriosis growing through to the mucosa of the bowel. That's pretty rare, but if they're getting that, then we have to think of that possibility. And the other thing that can happen is that if you have a lot of pain in your pelvis, and your pelvic floor can become very tight. And normally when we think about pelvic floor, we think about, oh, you've had a baby, you've got weak pelvic floor, we need to tighten it. But this is the opposite. This is people who have got spasm in their pelvic floor, and this can be incredibly painful, and it's really hard to get rid of this pain with painkillers, and surgery doesn't help this either. So the clues for this is if their pain is worse with movement, if they say, oh, I used to be able to run, now it hurts too much, I can't really walk very well. If it's worse in the morning, because sometimes when we're lying at night, we have more, our back tilts more, if that makes sense. And if they sleep with a pillow under their knees, the pain's often a bit better because it's not so stretched. Pain that goes down their legs, that stabbing pain where it feels like someone's putting a knife in their bum or in their vagina. That's also like a little thing to think about pelvic floor. Also, I've got some young patients who never had children who find they get stress urinary incontinence. And it's because normally with our pelvic floor, if you imagine it's on about 80% tight, and then if we cough or sneeze, it tenses more. If you've already at 100% of your tension, you've got nowhere else to go, so you are more likely to leak. So, that shouldn't happen if you haven't had kids generally, right? Then if you think about questions about central sensitization, the classic story is someone who's used to have period pain, then they started getting pain with ovulation and pain before their period, and now they just have pain all the time. And it just tends to be a bit worse with their periods. Often that's kind of switched to being sensitized. And they might have other pain syndromes, migraine syndromes, other pain things going on. We always have to think about trauma as well, previous trauma, and also the more global things, which you guys are probably far better at than me. But just, you know, if it doesn't all make sense, if there's other things going on, always think more widely. Basically on examination, abdominally, probably not the most helpful place to examine, but obviously if you're looking at undifferentiated causes, you've got to always consider other things. If they have a large adenomyotic uterus or an endometrioma, you might be able to palpate that abdominally. Sometimes people have got abdominal trigger points. So if you feel their tummy and it's sore and then you get them to lift their head off the pillow, if it's still sore, it's usually because it's in their muscles. Sometimes people get scar endometriosis and cesarean scars or laparoscopic port sites, which you might feel, or in their tummy button, which you might feel as a mass. Speculum examination often also is not very informative, but some people can get cervical or vaginal endometriosis, which you might see as blue spots. The main thing for me is the vaginal examination, the bimanual. What I first of all do is just when I'm examining, I just put one finger in the entrance and I just feel the sides of the vagina where these muscles here are. And if they're sore, oh, I've gone too far, hold on. If they're sore, then that's, you know, and replicate some of their pain, you think pelvic floor. The other muscle that's really tender is these ones are obturator internus. So what you do is you put your finger up at about towards 2 o'clock and 10 o'clock. And when their legs are abducted, you just get them to push them more out. And if that's the pain that feels like someone stabbed them in the ovary, but you're nowhere near the ovary, you're on the muscle. So that's a real sign that there's pelvic floor spasm. Then obviously you feel for the pain in the adnexa, you're looking for the mobility of the uterus. If it's not moving at all and it's retroverted, they've got deep endometriosis until proven otherwise. You might also feel a nodule in the pouch of Douglas. I have to say that these things here, the fixed retroverted uterus and the nodule and pouch of Douglas, even most gynecologists struggle to feel this. This is only something I really learnt when I started doing this surgery all the time and not really so much in my general gynae practice. So if you can't feel these, don't beat yourself up. But once you start feeling them, sometimes you think, oh my gosh, it's like a light bulb goes on in your brain. So the next thing is imaging. Ultrasound is our basic investigation. The things we can usually see, adenomyosis, as I said, think about endo, endometrioma. Sometimes scans say there's a hemorrhagic cyst. I'm always really skeptical when it says hemorrhagic cyst, unless they've got like no pain and then they suddenly get like a pain around ovulation. That might be a hemorrhagic cyst. So if they've got long-standing period pain, there's a hemorrhagic cyst, I'm going to guess that it's probably an endometrioma. Most of the reports say rescan in 6 weeks, because if it's a true hemorrhagic cyst, it will have resolved. If it's persistent, it's going to be an endometrioma. The other thing that they don't always report, but I look at the pictures, you guys are not expecting you to do this, but for your interest, if it says it's anteverted and I look and it's actually anteverted retroflex, like this question mark sign, then this is a sign that there's endometriosis in this space here, pulling the uterus backwards like a taco. So these people have usually got really bad endometriosis between the bowel and the uterus. More and more these days, scanning places are doing things like reporting sliding spines and tenderness. So that's when they're pushing on the uterus to check, is it moving against the other organs? That's just looking for signs of deep endometriosis. So more and more you'll get those reports. If they're really good, they may even see the lumps of endometriosis. Basically, no one's going to be able to see superficial endometriosis no matter what kind of scan you do. There are some research centres that are now able to see it, but this is like the best research scanning places in the world. But who does your scan does matter. Unfortunately, most of the time, like there's not a lot of options, but there are definitely, I know in Auckland, there's like some places like I know Ascot, and I had a patient went to Sonell the other day who got a really good report. Some of the sonographers are really trying to upskill in this. Obviously in this public system, there's not much choice, but this is something that's more and more going to be a specialised skill within ultrasonographers, is to get a good endometriosis scan. In Australia, it's all gone this way. Everyone just does endometriosis ultrasound scan, almost no MRI. So then I'm going to talk about the management. This is once again my hand, because whenever I see a patient, I think of these things. So the first thing we've got to do is manage the uterus/lesion. What I mean by this is basically I'm talking about hormones. When I think about hormones, what I'm thinking about is I want to have enough hormone to be able to stop ovulation, not just stop menstruation. And I say this because what I find happens is when I put a Mirena in my patients, sometimes they get a good result for like 1.5 years or 2 years. And then as the dose slowly drops, it's no longer enough to stop ovulation. So they start feeling cyclical pain, but they don't have any bleeding. But that means they're not getting adequately hormonally suppressed. So in that situation, I often explain what's going to the patient and top up with some more progesterone to try to stop ovulation or change the Mirena early. Any hormone will do. There's no real difference in trials between the hormones. Some people find that the pill doesn't always help them because it's got the estrogen in it, and really with endo, you probably want more progesterone dominant. But for some people, the pill is very great for them. But for a lot of people, you really need more progesterone. The main problem is the side effects, getting enough to stop ovulation while also managing the significant side effects people get from progesterones. And this is something which I spend ages with people. This is a journey. This is not a one-stop shop. This is something you really have to explain to patients what you're trying to achieve and why it's difficult for them. Because with endometriosis, there's progesterone resistance in the tissue, so you need a different dose of hormones than someone who doesn't have endo. And you've got to work together to figure out what's going to be the best hormone for them to stop their ovulation, but also to have the most tolerable side effects. And Mirenas often can be helpful because it tends to be a lower dose for more of an effect, but it's not for everyone. Pain relief, early NSAIDs. So think of NSAIDs as a prevention rather than a treatment when it comes to period pain. So the earlier you can take them in the cycle, the better in terms of release of prostaglandins and pain. Tranexamic acid if they have heavy periods. And then I think about surgery. That's if they're still having symptoms or if they're trying to get pregnant or if the hormones are not managing, there's a role for surgery as well. When I think about the bowel, I think about I usually have the privilege of having patients have a GP who's ruled out all of these other bowel things because I'm a gynecologist. I'm rubbish at this other stuff. You guys are the experts at knowing everything else about the body. So usually people have had celiac screening, you've thought about Crohn's, you've thought about everything else. So I generally talk to people about consideration of low FODMAP diet, which I think is best managed if possible through a dietitian. There's a few really good dietitians that I use, but also there's some good resources online. There's the Monash website, which is the university that basically came up with FODMAP protocol. There's a New Zealand page called Alana's Little Bit Yummy. She's a New Zealander, talk about low FODMAP diet, so she's got lots of recipes New Zealand based. The main thing with FODMAPs is people can't just cut them out and restrict their diet completely. You've actually got to add them back in, otherwise you end up with more sensitization. So that's, if people do it themselves, they tend to just cut everything out and not add it back. Whereas with a dietitian, they would add it back, which is, and also a lot of people have got other things with food psychology or previous eating disorders. So sometimes people need a careful consideration before excluding lots of food from their diet. The other thing I often use is amitriptyline in this situation because it's that visceral hypersensitization. Amitriptyline tends to be quite helpful with bowel and also bladder sensitization with endometriosis. Bladder, obviously, if you've got recurrent UTIs, you manage that. There's some dietary changes that can help, less acidic foods. Amitriptyline is a really good medication. And then pelvic floor physio is a really helpful person in your toolkit. The pelvic floor pain, there are some stretches. I think I've got a link at the end. I go to the Pelvic Pain Foundation and I teach the patient the stretches. The most important thing for them to know is if your diaphragm is rigid, your pelvic floor will be rigid because they're connected like a cylinder. So if people are trying to do the stretches but breathing up here, then their pelvic floor is not going to move. So when they do the stretches, they have to do the deep belly breaths. Pelvic floor physio is amazing. So I refer most of my public patients to pelvic floor. There's a long wait list, but I think we just have to keep referring so they can, if we get referrals, then they can hire more staff. I think with probably ACC going through, maybe more physios might be retraining as pelvic floor physios as well. So we might have more options or people in the future. But a pelvic floor physio is an amazing person to have in your armament. And they will, that pelvic floor pain is very intense. And if people have done a really good course of physio and they still can't relax their muscles, that's when we consider like pelvic floor Botox. Which I do have a few patients I use that for, but it's definitely not my first line option. They have to have it with the pelvic floor physio to really maximize that effectiveness. Central sensitization, This is where your MDT pain team come in. So that's with the neuropathic pain medications, goal setting psychologists. This is, I'm not part of a pain team. If they get to the stage where I've done everything else and they're still having a significant pain problem, I refer to the pain team too. And I know there's a lot of issues around access to that, but these are the really complex patients that are really the ones that are the hardest for me to see, because you feel like you know, you're not a success afterwards. But I think people do just really appreciate seeing the same person every time and having someone who'll walk the journey with them. Even if you're just fiddling with one thing every time, they still appreciate you being there. Thinking about previous trauma, I think that my physio, most of my patients tell my physio more than me about their previous trauma, and then she can often help with funding them through ACC sensitive claims process. And the last thing I think about as well is fertility. So when I'm thinking about treatment, I think about the Fimbria, fertility. If they have a fertility problem, then we really need to know what's going on. If there's evidence of deep endometriosis, their tubes might not be working. If there's superficial endometriosis, surgery for that may improve their fertility. So referral for surgery if someone's trying to get pregnant is very important. Surgery for endometriosis, it really matters who does your surgery. This is someone who's got some bladder endometriosis. So they've got this big nodular disease here. This is what I did. I excised it. And this is how it looks when you go back in. I went back in for another reason. I don't tend to try to go back in, but this is what it looks like. So you want to remove all the endometriosis. Ablation is pretty crap. This person here, they're having these little black lesions ablated, but look at all this red stuff here is endometriosis that they haven't even seen. So the problem with ablation is that there's a lot of disease which is not treated. So I remember hearing when I was a gynae trainee that you get a 40% recurrence rate of endometriosis. In my experience, the actual data is if you excise it all, it's less than 5% at 5 years. So I think there's a massive difference between ablation and excision. Also, the other thing I've learned is in my training, I got told 50% of diagnostic laparoscopies for pain are going to be negative. In my experience now that I'm operating on my own patients, I've had 2 in 5 years that have been negative out of, I don't know, hundreds that I do. Because I'm better at seeing the endometriosis because it can be extremely subtle. So for example, this is one of my young patients. This is near her bowel. These tiny little blebs, this is all histologically proven endometriosis. And I teach my registrars this now, and they all, I mean, I've seen hundreds of cases at this training, and we said it was normal. And that must be so messed up in people's brains to get told that it's just more gaslighting, right? And we tell someone that it's normal, but it's not. So I think I'm a bit cynical when I hear about negative laparoscopies. And if a general surgeon does it at the time of an appendectomy, they could have severe endometriosis, and you wouldn't even they won't even know what to look for. So I think we do have to. This is something for our profession as well. Get better and better at looking for endometriosis and treating it, and then also it's becoming more of a subspecialty as you're an endometriosis surgeon. We don't just diagnostic laparoscopies shouldn't exist anymore. We should be doing one operation, treating it well, and do it once, do it well. It's kind of the ethos that we should be doing these days, not multiple operations. Have a look. It's too hard. We need to do it once, do it well. And just briefly talk about adolescent endometriosis. So I get a lot of patients. I'm sure you guys get a lot of patients, young people, severe pain. Is it endometriosis? The mother's with them, the mother's got endo, what should we do, right? So I think the first thing is always acknowledge that yes, it could be endometriosis, right? 1 in 10 women have it, and we don't know that it's not. It could be primary dysmenorrhea as well, but it's going to be difficult to know. I think saying yes, it could be. If it is endometriosis, this is what I tell people. The problem is that if they have a laparoscopy, it's going to be really almost invisible to see when they're very young. So you end up with more chance of a negative laparoscopy. You end up with an incomplete excisions. So there's a statistical increased likelihood that you're going to have more surgeries the younger you have your first surgery, and the less pain benefit you're going to get from your surgeries. So the best thing really to do is to not do a surgery too young. Hormonal suppression, proper hormonal suppression is very important because we need to stop their pain cycle. Otherwise, they're going to increase risk of sensitization, and they've got to function to go to school and have a full life, right? Having a teenager that's at home all the time because the pain is not good for their mental health or their development. The mother's going to ask, But if she has surgery now, will that mean that she will have better outcomes, fertility in 10 years or 20 years? No evidence to show that. As long as we're suppressing the symptoms, I think there's no evidence to show a benefit in fertility in 10 years' time for surgery or not surgery. So that's usually the mother. Even if they don't ask, I always say that because that's what they want to know the most. So my take-home messages are endometriosis is extremely common, 1 in 10. Always think about it as a differential and discuss it. Patients are really, they love their GPs who get this, right? They just rave about them to me. And they've seen other people who don't even talk about it as an optional, tell them things are normal, but their GPs who discuss it with them, they're like, this is the best GP in my life, I love them. Talk about it as a differential, you know? You don't have to send anyone off, not everyone needs an operation, but you talk about it as a differential, and we've got all these things that we can do to manage. Really validate that this is not normal, that it is a problem for you. This is not going to be something that you can sort out in one appointment. I think making that expectation clear, like I can't sort this out in one appointment. No one can. This is going to be a journey of trial and error, getting the right thing for them to stop their periods and to figure out each of their little symptoms, what's going on, let alone investigating all the other things it could be. I always talk about using hormones to manage symptoms. I say not to mask symptoms, we're managing, which is different. You hear a lot of people just saying, oh, they've just masked my symptoms. Who does the scan, who does your surgery matters. There are, in the public system, often there's not much choice, but I think we really are improving a bit, particularly in bigger centres where there's more people available. We're trying to do more, just a smaller team of people do all the surgery for endometriosis to get better outcomes. Surgery is not the whole answer at all. This is a chronic condition with many problems that we can deal with as a team. And I've got some good resources that I give to most people. So for ourselves, these are some, Ranscog's made an online module, which is really good for people who are interested. It's free. You can just make a login. There's some guidelines, ESHRA, and there's a New Zealand guideline. For patients, I usually always send them this Jen Hale's website. I think it's really good. It's got lots of very accurate evidence-based information. It also talks about things like supplements. It's, you know, because people can get really sucked into this wellness world of people trying to sell them stuff. Just go off your pill and buy the supplement. So this has got some quite evidence basis around different supplements, different naturopathic stuff. Endometriosis New Zealand, and then Pelvic Pain Foundation is an Australian group who I really find a very helpful website. They've got a PDF of stretches. They've got a free ebook around all the aspects of pelvic pain, information about symptoms, painful sex. There's a page on that. Amitriptyline, there's a page on that. FODMAP, there's a page on that. So that's, to me, a really, really helpful resource as well. And those are kind of the main ones that I use. That's me.
Thanks so much, Sarah. And I think we'll move straight on to you, Silipa, and then do address some of the questions at the end. Thanks very much.
So hello, good evening, everybody. I'm Silipa. I'm a gynecological oncologist, and today I was going to talk about endometrial cancer and the red flags for gynae cancers. So just an overview for today. I was going to talk about endometrial cancer, which is the most common gynae malignancy and the increasing trend in young women. Also talk about what tests are required in the primary care setting when you see an abnormal vulva, cervix, or pelvic mass, and also gynae cancer flags. In New Zealand, so these are the 10 most common malignancies. The first one is breast, endometrial cancer, or uterine cancers. They classified it here in the New Zealand Cancer Registry. It's actually the 5th most common, and ovarians further down. So breast has a lifetime risk of 1 in 8. Colons about 1 in 20, and with endometrium about 1 in 36, and with ovaries much more uncommon, which is 1 in 78. Today I'm mainly talking about epithelial or endometrial cancer, and this is really cancer that's affecting the lining of the endometrium, as opposed to uterine cancer, which is a smooth muscle tumor. Globally, endometrial cancer is the most common tumor that occurs in postmenopausal women, and it has quite a high disease burden, especially in high-income countries. And as the world population grows, the prevalence of risk factors increases, including the disease burden. Uterine cancer continues to increase, and in the past few decades, this has increased by at least 132%. By 2020, cases were doubling in women under age 40. And this study was released last year that looked at the time trends of the global endometrial cancer burden in different countries. And SDI refers to the socio-demographic index, and this takes into account a country's fertility, educational status, and the lagging per capita distribution. And a high SDI, which you can see where the arrow is, refers to a country like the US, and low SDI will be like a country like Ethiopia. And globally, the peak incidence of endometrial cancer is somewhere between 50 to 60. But you'll notice here that in the high SDI countries that there's rising early cases in age 20 to 30. And New Zealand will be in this group. By 2019, the incidence of endometrial cancer for Pacific women was about 80 per 100,000. And this is about 3 times higher than Maori, which is about 30 per 100,000. And this is about 6 times that of European, which is about 13 per 100,000. And according to the New Zealand registry in 2019, Pacific has had a 129% increase from 2011 to 2020. This linked the census data, mortality data, and also the cancer registration, and it showed quite an alarming increasing endometrial cancer incidence in Pacific women under 45. This study here is based out in Middlemore Hospital, which is in South Auckland and caters to the highest density of Pacific Islanders here in New Zealand. It was really a retrospective study that looked at patients between 2000 to 2014, and it aimed to look at the incidence and trends and outcome of endometrial cancer. And what you can see here in the top left corner is that the age-specific incidence increased from women in Pacific women for as young as 20. And in Maori from as young as 30 onwards. In the bottom left, when you looked at endometrial cancer by age group and ethnicity, Pacific made up predominantly the younger groups from age 20 to 50. And if you look at the top right box, you'll notice that majority of the class 3 obesity were in Pacific women. The bottom right looked at time trends, and in all the 3 groups, endometrial cancer is increasing over time. They also looked at the disease-specific survival, and what was reassuring here was that the under 50s did better than the over 50s. The risk factors for endometrial cancer includes estrogen excess. So that means that, and it's associated really with obesity. So if your BMI is over 40, your relative risk is 7, as opposed to if your BMI was 25 to 30, where your relative risk is 1.2. If you are Pacific, then your relative risk is 5. If you had type 2 diabetes, that was 2. But also this increases with also hereditary syndromes such as Lynch and Cowden. We know that with these tumors, they spread through direct extension, so i.e. locally through the uterus tubes and out through the peritoneal cavity, and about 20% have lymph node involvement, and very rarely, so only about 8% will have metastatic disease. Patients present usually early with abnormal uterine bleeding of some description. And so this either will be abnormal periods, intermenstrual periods, and postmenopausal bleeding. In patients who present with postmenopausal bleeding, only about 10% of them will be from endometrial cancer or some other sinister pathology. 90% is usually benign. They also present with some form of abnormal vaginal discharge, or they can incidentally be found on cervical cytology. We also know that you can find it incidentally at hysterectomies, and this chance of finding it at hysterectomies is really higher in women who have postmenopausal bleeding or who are much older. In terms of the investigation that can be done in a primary care setting, one, cervical screening, so ensure that the patient's up to date with the cervical screening, and also endometrial sampling, and a pelvic ultrasound scan. You only need the MRI and chest X-ray or CT, chest, abdomen, pelvis, after endometrial cancer has been diagnosed, and this is usually done in the secondary care setting. Endometrial propels can be done in clinic, and in postmenopausal women, this has quite a high sensitivity of 99%. And the hysteroscopy DNCs really is done in the secondary care setting. But the PEPALs are, they have high sensitivity and they're easy to do, especially in an outpatient clinic or even in the GP practice. And I understand that this is also done out in GP setting. Pelvic ultrasound scans. So the cutoff with postmenopausal women is 5 millimeters. And if the risk of endometrial cancer is about 1% if the endometrial thickness is less than 5 millimeters. And we know that as the endometrial thickness approaches about 20 millimeters on transvaginal scan, that you need to be suspicious for cancer. It's a bit different in premenopausal women because there's really no standard threshold. And it's unclear what endometrial thickness correlates with cancer in this group. Roughly in the proliferative phase, the endometrium should be somewhere between 4 to 8 millimeters, in the secretory phase, somewhere between 8 and 4 millimeters. Traditionally, endometrial cancers were classified as type 1 and type 2. Type 1 meaning it's estrogen excess. They tend to be low grade, good prognosis, versus the type 2, which is not related to estrogen excess and have poor prognosis. But this is these were the traditional views. There's newer classifications for endometrial cancer. And in 2013, a Cancer Genome Atlas published a comprehensive genomic analysis of endometrial cancers. And this has really changed our understanding of this and led to the discovery of quite distinct molecular subgroups. Using these specific molecular markers, they went back and looked at tumors in other big endometrial cancer studies, and they found these trends that patients, for example, if you look on the bottom left, the blue line at the top, and these are survival curves, and those who had polymutated tumors did the best, whereas the red line, and these were like P53 or serous-like tumors, did the worst. Currently, there's mainly, you'll find that in the gynaecologic setting with these patients, and the letters that I'm sure that you're getting from us will have these molecular classification, and it is prognostic, and this is mainly based on retrospective data, but some of our treatment is not necessarily being changed by this because the prospective data is not going to be mature for the next 10 years, but it gives us prognostic information. Nationally, with endometrial cancer, there is universal screening for Lynch syndrome, and about 2 to 3% of all women with who are diagnosed with endometrial cancer will have Lynch syndrome. So that's only 2 to 3%. But we know that in 50% of patients, 50% will present with endometrial cancer in terms of their index cancer. This is the figure 2009 staging for endometrial cancer, with stage 1 confined to the uterus, stage 2 down to the cervix, stage 3 is beyond that, and stage 4 is distant metastases. So this is staged surgically, and the reason this is staged surgically is based on this paper published in 2003, which showed that clinical stage 1 did as badly as those who were surgically stage 3. So the standard management is surgery, and this can be done either open or laparoscopically or robotically. And we know that based on randomized control trial, these two randomized control trial, that the survival is no different with laparoscopy versus laparotomy. And laparotomy is really reserved for big tumors or patients who are unable to tolerate steep Trendelenburg or unable to tolerate a laparoscopic procedure. And it's really reserved for those with advanced stage where we're able to remove all tumor that we can see with our naked eye. And surgical staging involves a hysterectomy, BSO, pelvic lymph node assessment, and removal of all tumor we could see if that's present. And so standard management is removal of that uterus and tubes and ovaries. And because of the rising incidence of cancer in women who are under 45, this is a big deal for them because this means the loss of fertility, but also means premature menopause, which is associated with a reduction in all-cause mortality, increased risk of osteoporosis, increased cardiovascular risk, impaired cognition, all of which have irreversible implications. And so specifically for low-grade stage 1A, that this means the cancer only involves less than 50% of that myometrium, we can consider conservative management. And this is where we give them, treat them with hormones, i.e. Mirena plus minus oral progesterone. And the response rates for that's about 50%. If you add the oral progesterone, it's about 60 to 80%. However, during this time, this is where we need, especially input from GPs and from mainly to do with trying to reverse their reversible risk factors, i.e. their obesity, diabetes, hypertension, and trying to optimize those comorbidities. Because during this time, they still have about a 25 to 40% risk that this cancer will remain persistent or it progresses. And even if this resolves, they have a 25% risk of recurrence. In this particular group, we can consider preserving their ovaries. And we know based on the systematic analysis that there's no difference to their survival if we preserve their ovaries or not. In terms of the adjuvant treatment, this is usually through the multidisciplinary meeting due to the complexity of evidence. And the options are either surveillance, radiotherapy, plus minus chemotherapy, and in advanced cases, hormones, immunotherapy, and clinical trials. Overall, the prognosis is good. 85% we will see at stage 1. And so they have really good prognosis. And even for stage 3, now, where all the tumors removed and they get chemoradiation, their survival is up to 79% in 5 years. And so even with stage 3, who are completely resected, the intent of treatment is still curative. I thought I'd put this up in terms of patients who've been treated with endometrial cancer and cervical cancer. This is the national guideline for follow-up. And so you can look it up at the New Zealand Gynaecology Cancer Group guidelines, and it tells, and it's a guide for both gynecologists, and also GPs in terms of the timing to follow them up, and also what needs to be done. What to do with an abnormal cervix. And so if a patient's symptomatic or asymptomatic, essentially the things that are useful in that setting is a full history and exam, a pelvic exam, and what would be most useful really is HPV screen or a cytology in that setting. If there's a clinically evident lesion, then if they have a capacity for biopsy, then that would be also very helpful. And a referral on. For an abnormal vulva, the symptoms that you're looking for really is patients who've had previous pre-invasive disease of the vulva or previous skin conditions. And their symptoms usually involve itchiness, burning, and painful vulvas. Sometimes they find a lump or a swelling, pain, or they have a mole that's changed in time. And so a full history, a vulval examination. And what we find really, really helpful is pictures, because sometimes it's very difficult to describe these lesions. So a picture is more than adequate. And if you can do a punch biopsy, that's also quite useful. Pelvic masses, pelvic ovarian masses, are also can be a bit complex, because the only way, pelvic masses are quite differentiated rather. This could either be from the uterus, ovary, tubes. It could also be from the bowel. And so the most useful test to be able to differentiate between them really is a pelvic ultrasound scan. And tumor markers in this setting is only if you find an ovarian mass. If an ovarian mass is present and the patient's under 40, then you do a CA125, CA and CA99, because this gives us an idea as in risk profile for epithelial tumors. And you can also add in LDH, HCG, and AFP because they're a marker for germ cell tumors. If they're over 40, then just a CA1 to 5 CA and CA99 in that setting is useful. These are the gynae cancer, high suspicion for cancer red flags. And so part of this list is an abnormal vulva, vaginal or cervical lesion, abnormal vaginal bleeding or discharge, including pelvic pain, or you have abnormal clinical findings, i.e. you're finding lymph nodes, vaginal nodularity, or pelvic induration on exam. Any patient with postmenopausal bleeding, a rapidly growing pelvic mass or genital lump over 3 months, or an incidentally found pelvic mass. And women who have documented genetic risks, i.e. BRCA or Lynch syndrome, who have suspicious pelvic symptoms or abnormality. The take-home points are in women, especially in young women who have persistent abnormal uterine bleeding that are not responding to treatment, or who have iron deficiency anemia, or who have other risk factors, high BMI and ovulatory cycles, that to consider atypical hyperplasia, which is the precursor to estrogen-related epithelial endometrial cancers or endometrial cancers in your differentials. Optimizing reversible risk factors, i.e. BMI and the metabolic syndrome. Consider the gynae cancer red flags and refer on. And also a handy information follow-up guide is in the gynae cancer group guidelines. Thank you.
Thanks so much, Silipa and Sarah. So we're going to go through some questions. There's a bunch that have come in, and I think we'll just start. We'll come back to you, Sarah, and give Silipa a bit of a break before we go to some questions for her. But if we can go through some of the investigations and treatment with endometriosis with you, Sarah. So the first one that's come in is around, does it matter what time of the menstrual cycle you do an ultrasound scan for looking for endometriosis, or will it show up on ultrasound scan at any time during the cycle, or is it specific to different times?
I think if it's on ultrasound, you can see it any time. Endometriomas don't go away; they just stay there, so you can see them at any stage. Deep endometriosis also doesn't come and go depending on this time of the cycle. It can get a bit more swollen, but yeah, it doesn't matter about timing.
So either it's visible or isn't. I think is
yeah.
Okay. Brilliant. So that's good to know. And a couple of questions around treatment. So things like the Gynae implant, does that work, or is that a possible use for management? And also you mentioned amitriptyline for pain management. Is nortriptyline just as effective, or also could be used?
Yeah, you can use nortriptyline as well. It's fine. Usually people start, I don't know why they start with amitriptyline. If there's some problem with it, they go to nortriptyline. I think you guys prescribe that way more than me, I have to say. But yeah, it's definitely both. Gynae, basically you're looking for menstrual suppression because it hurts when people bleed. So the problem with the Gynae is a third of people are going to get it taken out because they bleed all the time. So in my mind, it's not as effective. But for people who it works for, it's going to be fine. But I think if, when you're going through choices with people, I think it's just to be, if there's someone who's going to get bleeding all the time, the pain's not going to get better. But if the progesterone is enough for them to suppress ovulation, then yes, it will work. It's a bit tricky because every person is different. Everyone's metabolism and volume, whatever. There's a lot of differences between people, so it's hard to tell, isn't it? And there's no magical way of knowing. Like when we're starting a pill, we don't know which one's going to suit someone, which one's not. It's all about explanation to patients and trial and error working together.
Individualized care.
Yeah.
There's a question also around how, because obviously the contraceptive pill works as an option for management. How do you have some advice around how young you might put someone on the pill to manage endometriosis in this setting? Do you have a particular cutoff line?
As soon as they start their period. No, it doesn't really matter. They can do it whenever. We put Myrenas in 11-year-olds or 12-year-olds with cerebral palsy, or, I don't think you can just do it. It doesn't matter as far as I'm, if they've got pain and they're not going to go to school and they're too sore, of course we can. The main issue is really the mums thinking that they're going to have sex. Like that's mostly the big barrier that you really have to work through. I'm sure you all know that, but it's not going to cause them any issue with fertility later. the problem is there's all this stuff on TikTok around like this hormone hesitancy. You guys
Yes.
probably see that. And I've got suspicion, at the same time as no abortions in the States, there's all this stuff around how the pills are bad for you. And one of the things you hear is, I was on the pill for years and then I came off it and I had PCOS or endometriosis, as if the pills caused this. Whereas we all know the reason they were on the pill when they were young is because they had PCOS or endometriosis when they were young, and the pill has managed their symptoms quite well for 10 years.
Yeah.
So I think it's all about how we explain, but this is what we're battling, is this social media kind of stuff, isn't it?
Yeah, and I think that whole education piece has to be a huge part of it, is how you frame it for the person or the parents or both in front of you in that kind of situation. How there is a question around suppressing. Can you clarify why suppression of ovulation is as important as flow control in endometriosis?
It depends on the kind of pain they have. If they're some people are fine with having cycles, with making estrogen and release. When you ovulate, you get a burst of estrogen release. Some people don't get a lot of pain with that, in which case it doesn't really matter if you suppress ovulation or not. But for a lot of people, they're getting pain with the cyclical changes in hormones causes them a lot of pain. So you need to stop that by stopping ovulation. It's not just the bleedy part, it's the hormones going up and down that hurts, if that makes sense. Mainly to do with estrogen. Yeah,
and it comes down, I think, to that same personalized or individualized treatment plan. So if they're not getting significant ovulation pain, it's not so much of a focus for each.
I just specifically said that because I still know as a gynae reg, and I still hear my belief in my gynae registrars now, I have to tell them, they say, oh, they're not bleeding on the Mirena and they're having pain, so it can't be endo. And I think we just have to think, the patients usually tell you, they're like, it feels like I'm getting my period pain, but I'm not bleeding. So, patients usually tell us the answer. And those people, we need to stop their cycles to truly know, because even if we do surgery for them, if we can't suppress their ovulation, they're still going to have cyclical pain. So we need to know what pain is left over after we suppress them, really, to kind of understand the benefit of surgery, if that makes sense.
Yeah, absolutely. Silipa, we've got a question for you, which is, so you've presented some pretty sobering stats on endometrial cancer rates and I guess what we're seeing in different populations. There's a question around, your thoughts, or what is the evidence showing about why it is occurring more often in younger women? Why are we seeing it, that sort of increase in the younger age groups that we hadn't really understood or known about before? And has there been a change, or have we not picked it up in the past?
We think it's obesity related, to be honest. We're about to publish, because initially the other thought was whether this is related to Lynch syndrome, but we don't think that's, we're about to publish on this, but basically Pacifica's overrepresented in it, but this did not translate to Lynch syndrome. We think this is obesity related.
Is there a significant number of Lynch syndrome within Pacifica patients?
No.
Right, okay. And
year-old middle more with endometrial cancer,
and probably a question for both of you around the scanning. So in investigation, so there's a question around ultrasound versus CT versus MRI. So I think there's a significant part of both your presentations are around ultrasound scanning being the primary investigation. Is that being less invasive, or are you just getting enough information from ultrasound scan that you'd often not needing to go to CT or MRI?
So not for cancer. So I think the reason I put that up there was really for the diagnostic part, right? So a patient that presents with abnormal uterine bleeding needs a pelvic ultrasound scan and a transvaginal scan just to look at that uterus and at that endometrium. In a postmenopausal setting, regardless of that endometrial thickness, you'll be more suspicious if it's thick, but if they present with postmenopausal bleeding, they still need a sample.
Okay. And in terms of endometriosis, worldwide, endometriosis ultrasound is a specialty, and they have 45-minute long scans just looking at endometriosis. And there's a subspecialization in our college, which is just about ultrasound, which is mainly focused on obstetrics, but more and more doing endo scanning. So this is a specialized area. And when you have access to that, the complex endometriosis surgeons are also doing scanning themselves, which is a skill that we're picking up. But you don't need an MRI. Then the only reason you need an MRI is to assess how deep it's gone into the bowel, to know if how much of the bowel you're going to chop off. That's really the only reason, if that makes sense. So, but currently that's the ideal, and that's happening in Australia, that's happening in the UK, that's happening in places with good, very subspecialized ultrasound units. Currently in New Zealand, we're not doing that at all. What's happening for us is people are getting an undifferentiated scan, which is usually normal, even in severe disease. And then we are having to try to figure out which one. We do a lot of MRIs, but even MRI, I have to say, depends on who reports the MRI. There's because with anything, the more you do of it, the better you are at it. So ideally, you kind of want an endo MDM would be, ideally we need a centre of excellence with a really good scanner and a really good person at reading MRIs, which is actually what's we need in the Women's Health Plan, is in the Women's Health Plan, I think. That's kind of what we're pushing for, would be regional centres of excellence, because this is not like having a little fiddle and you can't be good at everything. This is stuff which we could do with our resources. That's it is cheaper, but also if you can get better information, then we should be doing that, right? I don't know.
Yeah, and I think that was one of the other comments that has been made, is how do we advocate for, it sounds like a multidisciplinary clinical space is the way to go, and how do we advocate for that resource?
I think politically, whatever force we can use. I mean, wasn't it amazing that we got the Women's Health Plan under the last government? I haven't heard a lot about what they're going to do with it this government. Continuing to, just pushing for that to be a priority. The biggest problem that I have, I know I've been working Middlemore for 12 years now, and for 10 years, well, for I don't know how many years, Doug, 5, 6, 7 years, we weren't seeing anyone with pelvic pain, because we were our managers were managing our surgical wait list to meet their KPIs by turning away all referrals that weren't possible cancer. So we didn't see any incontinence or pelvic pain. And now that's happening in Christchurch and Waitakere. We're still seeing them because we decided we were going to start seeing them again. But to try to, whenever a government has got surgical wait time targets and FSA specialist appointment targets, the only way that managers are going to meet their KPIs is by not seeing stuff which is not cancer, it's going to be pelvic pain. So this is an imminent problem that we're going to face. It's great to have your surgery soon, but most people aren't going to get surgery who needs it. So this is, this is a political thing, right? When you set targets, this is the consequence of the target setting.
So it's a call to arms to advocate, to ask and request and write.
And I think mainly the problem is, right? It's a problem that needs to be solved at a higher, I can't fix that one. I've tried. It's really got to be a national discussion, and advocate to your MP, talk about your stories.
Yeah, and you're right. I think we've there's a whole lot of us that have worked through that time where we couldn't refer in, we couldn't get
lots of GPs in New Zealand are working at the moment more than they used to be, because we're now taking, but lots of other places aren't, and they're going to stop, because that's the only way you can manage your wait list is by seeing these patients. There you go, everyone.
Sorry. Take that as a call to action from Sarah. So back to some more questions, but we'll take that away as well. It's good. How long? There's a couple of questions around the hormonal treatment versus surgical treatment for endometriosis, and how long do you persist with hormonal treatment? When is enough, and when do you move to surgery? And I think people have differing experiences of being offered surgery earlier versus long waiting and trying different.
We talk about like individualized discussion, patient goals. The biggest issues that you guys are going to have is, do they have insurance or not, as to how long, because if you refer public, you might not even be seen at all, versus you might not even be surgery, might not be an option because their referral gets declined. Or even if they get seen, it's going to be maybe an appointment a year later and then surgery a year after that. So you've got to do something. I think this is stuff that you can do in the meantime. Like this is, even if they're on a wait list for surgery, this is all stuff that we can all think about what we can do if patients are coming to you in the meantime that we can tinker with. Privately, you probably all know some people operate more than others, or I don't know. I think it's really depends on the patient, and I really don't like to operate on teenagers, but I still have operated on a couple of teenagers basically I try to get them suppressed, and if they've still got pain, or if it's just really hard and we're really struggling, I'll do surgery. But never in my first appointment I would offer a teenager an operation, pretty much. Not even my third. This is because they've got to still have an idea of how we're going to suppress afterwards. And we try to and second surgery even less. So before I do a second surgery, every single other thing has to be addressed, right? Like if they've already had one surgery for endo, getting to a cycle of, I've got another pain after 6 months, I need more surgery. This is not going to be a good long-term pain-free life for this person by doing repeated surgeries. We're going to do one surgery well, and then we need to address everything else needs to be addressed. Whether you address it before or afterwards is kind of the question, but it still needs to be addressed, all that other stuff, right?
Yeah.
So, yeah.
No, that's really helpful. Thank you. Silipa, there's a question around, so you talked a bit around postmenopausal woman presenting with bleeding, so abnormal uterine bleeding. And there's a question around are papals the first sign of action? And can you just talk through your approach to postmenopausal woman presenting with abnormal bleeding or bleeding when unexpected bleeding, and how you would start to address it and step through the investigation process?
Yeah, I mean, for postmenopausal bleeding, 90% of the time it's usually from a benign atrophic cause, 10% is from cancer. It's usually the 10% that we go hunting for. And so history exam, pelvic exam, cervical cytology, definitely make sure their HPV screening's up to date, and an endometrial papal and a pelvic ultrasound scan. That would be the first three things. Yeah.
Brilliant. And for a referral, are you expecting all of those things to be done prior to a referral?
Ideally, at least I appreciate that the papals are not done universally in a GP setting. And so at least the cervical screening that's done, and ultrasound scan if possible, because that helps, especially when you're seeing them for the first time, deciding whether this is somebody who can just get a papal versus a formal hysteroscopy D&C. Because if you're seeing a really thick endometrium, unless that papal definitely shows cancer, you're still gonna get a formal hysteroscopy D&C. So having that just kind of limits the number of future appointments they need to have. They can just get one appointment and get that all sorted.
Brilliant. And I think there is differing accessibility across the nation around ultrasounds even. So if that's referred to publicly, there's different criteria and obviously wait list as well. So I guess, again, it's all that approach, how we do it across the nation and how we access things across the nation. But the more we can show that there is a need, hopefully we will progress with a bit more of a call to action, like Sarah said. There's a couple more comments about treatment for endometriosis. I think depot is probably similar to Jadelle, I imagine, Sarah, where some women bleed for the first, a lot of women bleed for the first 3 months, and that could potentially cause more issues for them.
Some people on depot who are really well suppressed, probably more so than Jadelle. It works a bit better, I think. Jadelle tends to have way more bleeding problems, I think. I don't know. What do you think? I don't.
Yeah, I mean, again, probably quite individual, I think, but yeah. Definitely.
I think there's people asking what hormones I add. So if I have someone with a Mirena in and they've still got, the good thing is contraception's already sorted, so we don't have to worry about that. So I tend to think about, could I add norethistérone? So you can add, the top maximum dose is 15 milligrams a day. So you can start off with 5 milligrams or 2.5 and you can go up.
Yeah.
Generally, hormonal side effects happen really quickly with hormones. So people's mood will change very fast. And as soon as they stop it, their mood will get better again very fast. But the bleeding pattern takes a while to change. So I do tell people it might take 2 or 3 months for the bleeding pattern to sort itself out. But if they're going to get side effects, they generally know about them pretty quickly. So norethistérone, you can add Cerazette, but that's a cost. Or the other one I give is cyproterone, 12.5 milligrams to 25. That's not in a guideline, but lots of endometriosis specialists do that. It tends to work quite well. And it counteracts, because I don't know if you guys notice, Mirena often, the progesterone in the Mirena is quite androgenic, so people get acne, hair loss, sometimes, and so the cyproterone is anti-androgen. So I find that tends to be, for some people, a very good combination. But that's probably not, most GPs would probably feel not comfortable about starting that because it's not in a guideline. So I can understand who get worried if they do something off paper, which I probably got more ability to do. But just norethistérone, just even the pill on top, just something that's going to help to suppress ovulation, whatever they can tolerate.
Brilliant. And I think we also, in different areas, we have ability to write and ask for advice. So we can potentially do that through the puppet system where
it depends on who answers the grading. Though I'm not allowed to grade at my hospital because I was going to, because this goes down to when we weren't allowed to see people with pelvic pain because we got told we want to see everyone, so we weren't allowed to do grading. So, but we're trying to start doing grading again now because we actually want to give some good advice.
Yeah. As options, because that's really useful, because then we can try and start things in the community sector. So Silipa, back to you around propels. There's a few questions coming in around propels. There's one specific one, propel and postmenopausal bleeding. Occasionally, this person has found the cervix very tight and the propel gets twisted in the process. Any advice on how to improve technique? Should I dilate prior to inserting the propel? And then there's another round around making sure the propel technique is adequate. And am I getting a representative sample, or am I getting a false negative result? So can you speak a little bit to the people that are doing propels in our communities, which we really want them to be doing?
So yes, in terms of, so excellent for doing propels in the community. In terms of the technique, yes, it sometimes gets a bit twisted. So what you can do is actually use a tenaculum, and you want to straighten the cervix. So you kind of want to make it a bit axial, if that's one way of describing it. So one's grasping that anterior cervix with a tenaculum and straightening that axis to pop that propel through. And occasionally, yes, you might need to dilate it. Yeah, I agree. And then you said something in terms of adequacy. Well, a propel will only sample about 50% of that, 50% of the lining of that endometrium. And so how will you know it's adequate? You need to know that it's gone beyond that internal loss. So if you're sounding to more than 6 centimeters, you know that you are in that endometrium. And also you correlate that with your ultrasound scan. So if you have an endometrial thickness that's thin, so under 5 millimeters, and your sample is scanned, that's quite reassuring. But what this also means is this: if in 3 to 6 months' time they still have persistent postmenopausal bleeding, that is still a concern. So they still need to be re-referred for another look. Yeah.
Brilliant, thank you. And there's a question about how common is it for endometrial cancer to present with no history of postmenopausal bleeding?
It is uncommon, but it does present, yeah. And sometimes it's an incidental finding of a thickened endometrium, where you have cervical stenosis. Yeah.
I was asking about Lucrin. There was a few things about Lucrin.
Yes, that was.
I do use it, but I think that would be, you'd have to have a specialist to say that was okay for endometriosis. But the reasons I use it is in middle of a hospital when we've got severe endometriosis and they're on a long wait list, so to manage the symptoms. Or we use it sometimes if they've got a big fibroid and we're trying to do the surgery through a smaller hole with less bleeding. We use it pre-op. Or I've got some patients who are perimenopausal who they don't want to have a big operation involving their bowel, and if we can get them through menopause, they can avoid it. So we're just, giving it till menopause. I generally add back estrogen, or sometimes we start with norethistone and then we add a bit of estrogen if needed. I also, I've got some other patients on it where we just try every single other thing to stop their pain and bleeding, and we're just giving them a bit of a break. But then there's and to see if stopping their hormones actually helps. Because you're adding on all these hormones, but some people are so sensitive to hormones that at least if you've stopped everything and their pain is better, it kind of is a hormone sensitive pain, right? But then the problem is what do you do long term, and it's really hard. And these are the hard patients. So don't.
Sarah, can you just explain for those, because that's a question about something called Lucrin, which is an LHRH blocker. Yeah. So can you just sort of explain that to the people that I
think the brand we use is mainly called Zolidix or Goserelin. So basically it's an implant it's the one you use for prostate cancer or breast cancer, same thing. So you guys probably give them, or your nurses give them. So it works it's a GnRH agonist. So it floods the GnRH receptors. So initially you get a big release of FSH, LH, and a big release of estrogen and progesterone. So for the first month you can have funny bleeding and a surge in pain, but then it blocks it because it's it binds for either 1 month or 3 months. It binds for a long time so that the GnRH can't bind to it and can't have that cyclical release. Does that make sense? Yeah. So basically it's a hormone blocker, so you get no hormones. So people can get the side effects of menopausal side effects.
Brilliant.
So you're going to feel all the things we feel with instant menopause, which is the unpleasantness. So I tend to add back estrogen. I think there was another question about HRT with people with endometriosis as well, which
That's
kind of
right.
goes with that. I never used to. We just used to give some, what was that, Premarin or something. That was what I was taught to do in training. I think from my GP colleagues, I've learned that we should be doing this. So thank you very much. It's a two-way learning street. I think particularly if you've got not completely excised endometriosis, then yes, we should be giving progesterone as well. Yeah. I mean, I've got lots of people who I haven't and they're still fine. But I think that's what the guidelines suggest is that you should.
Yeah, and there's a specific question around what progesterone, what dose is recommended. Is that something?
Whatever I don't think it matters too much because you don't have to worry about the endometrial protection. So
yeah.
So
it's more just to keep that balance, I think, for how the woman feels.
I think there's a talk about the risk of cancer. You probably know about this.
Sorry.
And people with endometriosis, if they've got deep endometriosis, they might get a malignant transformation if you give them estrogen. I don't think that's true.
There's no strong evidence for that, to be honest. Yeah, there's some association between clear cell cancers and endometriosis.
But I don't think that's because of giving people estrogen. I think that's probably just something to do with the cancer, the genetics of the endometriosis. It's more just to stop it from getting worse again, I think, and growing and flourishing if there's endometriosis there, causing them pain and symptoms.
Brilliant.
From my understanding. Yeah.
Great, thank you. And there's a couple of questions just around chronic pelvic pain. I know we're running out of time, but we'll just, if we can quickly address them. One was around, it says, given that those with chronic pelvic pain with and without endo have the same symptoms, should we validate these? How do we approach it, I guess?
How do you know they don't have endo? Like, do they not have endo? Are you sure? Yeah. I'm serious. I guess this is my, we have patients all the time. This is what I see in my training. People come to hospital with the chronic pain. Oh, they're a chronic painer. We all feel a bit depressed and a bit like, oh gosh, here they are again. This is our human emotions because we feel useless because we can't fix them, right? But actually, when you look at them, they've never actually been investigated properly, or they've had their laparoscopes have been done by people who don't know what endometriosis looks like, or they've had it by a general surgeon who've got, they've got no clue. So, I think we really have to be, and also we're crap at seeing endo, like literally. There's subtle endo. No, like so few gynecologists would know that was endo. That's not what we're taught in our training. We have to be cynical. But the actual thing that we need is a better test. That's a non-invasive test. There's some promising tests being researched. There's a salivary mRNA test, which everyone's talking about. I mean, I don't know if that's going to be the exact test, but imagine this, to me, the surgery that I'm doing, cutting all this stuff out, I really think that in 10 years' time, we'll be doing a salivary test and there'll be an expensive drug called Endomab that will give everyone, so I think this is going to change for the better, I hope, because right now it's quite hard, isn't it? And all we have to go on is what people tell us, that they've had their surgery, there's no endo. But I think we do still have to be suspicious. It's really hard.
It is hard, and thank goodness we have you guys, and I thank goodness, thank you for giving up your time. So much information from both you, Silipa and Sarah, today. Thank you so much for your practical information and the management tips and answering all the questions and giving up your time this evening. We really appreciate it. Thank you. Thanks again, team, and good night, everyone. Have a good evening.